So once again, welcome everyone, and thank you for joining us today. Before we get started, there are a few housekeeping items that I would like to mention. The slides and recording from today's webinar will be made available and sent to participants. You may enable or disable closed captioning on the main Zoom toolbar labeled CC. If you experience any technical difficulties, please notify me, Patrick Ahern, in the Q&A section. And questions for presenters can be submitted into the Q&A window at any time and will be addressed upon completion of the presentation. During today's session, we'll open the chat a few times for your participation. The chat feature is found in the main Zoom toolbar. So with that said, I'll now turn things over to Sari Schumann to get us started.
Great. Thank you so much, Patrick, and thank you everyone for joining us today for the National Alzheimer's and Dementia Resource Center webinar, Living Longer, the Increasing Need for Dementia Care and Support for People with Intellectual and Developmental Disabilities. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. Before we start, Chris Stockton of the Administration for Community Living will provide a brief welcome. Chris?
Good afternoon, and thank you all 575 plus people that have taken time out of your busy days to listen to this important topic. I would like to also thank Amy and Phil for taking the time out of your days to educate us on this important topic. And with that being said, 600 plus people. My apologies, I undercut. Sari?
Thank you so much, Chris. So as you heard, today's presenters are Dr. Philip McCallion and Amy DeWitt-Smith. Dr. Philip McCallion is a professor and director of the School of Social Work within the College of Public Health at Temple University. He is director of the ABA Centers of America Autism Lab, co-founder, co-applicant, and co-PI of the Intellectual Disability Supplement to the Irish Longitudinal Study on Aging, and consultant on intellectual and developmental disabilities and dementia for our resource center, the National Alzheimer's and Dementia Resource Center. Dr. McCallion offers trainings and technical assistance on case identification and assessment, caregiver support, and in the translation and implementation of evidence-based or evidence-informed non-pharmacological interventions for people with intellectual and developmental disabilities and dementia. We also have with us today Amy DeWitt-Smith, who is the founder and executive director of Neighbor Network of Northern Nevada, a 501c3 nonprofit organization focused on community building through human-centered design. She brings over 25 years of experience in aging and disability services and home and community-based Medicaid waiver programs. She enjoys teaching and learning, designing effective program evaluation strategies, and collaborating with local community organizations. At this time, I'll turn the presentation over to Dr. McCallion to begin. You are still muted, Dr. McCallion.
Well, then I just got that out of the way. So I want to thank the Administration on Community Living and the Resource Center for the opportunity to do this, because I think this is really important work. I just want to highlight here the learning objectives across our session, really sort of trying to cover some of the really key areas that really speak to intellectual and developmental disabilities and dementia, both for the individuals themselves and their families, and also to highlight, which will also be dropped into the chat, the link to the new National Alzheimer's and Dementia Resource Center Guide, Intellectual and Developmental Disabilities and Dementia, Practical Strategies for Professionals. This is not... So I always like to start, we often talk about people with intellectual and developmental disabilities and just how many are there. And people talk about 2-3% of the population, but what does that really mean and where do they live? And so we're got these data are from 2019, but the numbers are not that much different today, that it's about 7.39 million people. But then as we break that down, there's a difference between those who are known to service systems and those who are just living at home or living independently. Sometimes we think that most people are living in out-of-home placements, but the reality is the majority are living at home. And I think that that becomes really important as people get older, that we're often coming into contact with people who weren't previously known because they were not informal services. And when symptoms of dementia present, we may have people who are not well connected to service systems or knowing where to turn. And that's why the grants that are provided by the Administration on Community Living become so important because they're about building those connections for people. So I always also, before I get into assessment and the issues around symptoms, to remember that brain health is as important for people with intellectual disabilities as it is for all of us. In fact, all of us could be doing so much more. And just want to highlight the KAER framework that was put out by the Gerontological Society of America, that really that evaluation piece comes late in the framework. It really is having that brain health conversation. It's assessing for cognitive impairment, then it's evaluating for dementia. And it's also about, it's very important that we have the opportunity to refer people to community resources. And I think, again, that the work through the grants really is about building that network, that referral network, but also helping to build capacity or identify capacity for assessment and evaluation. So when people with intellectual and developmental disabilities get older, there's some things that I want to highlight that certainly that we're actually seeing people live longer. There was a time not that long ago when the average age at death was 36. Now we're talking about in the 60s, but it's still not as long as for the general population. But again, sort of want to highlight that people are living independently with family, they're living in community settings. What has really changed is that they are more likely to access healthcare in the community, and yet they're hidden in the community rather than identified. When they were children, individual education programs and plans help to identify them. That's less true as an adult. And as people get older, we see more chronic conditions at earlier ages than is true for the general population. And we're now starting to, just as we're talking about the growing numbers of people with autism, we're also seeing there are more autistic adults. Some of that is about these age trends, but some of it's about that we were not doing this, we were not as successful in the past in identifying individuals. So therefore, some people are being diagnosed as adults. Some of this is that it really challenges some of our prior service models. And one of the other things that we're seeing is the onset of dementia, particularly among persons with Down syndrome. I'm often struck by that this graphic, which I use a lot, was actually developed sort of in the early 90s, and it still holds true. What it really helps to highlight is that both the earlier onset of symptoms of dementia, both for people with Down syndrome and those with other types of intellectual and developmental disabilities, and also the higher rates at particular ages. And to realize that for people with Down syndrome, that about 75% people age 60 and older, that's very different from the general population where we're just starting to see percentages in the 10 to 15%. Here we're looking at 75%. So the work that we're doing to identify this needs to start earlier and needs to reach as many of the population as possible. So signs and symptoms, because people have prior disabilities that may be influential, because people may not have the same level of communication skills as in the general population, we have to look a little harder sometimes. And so some of these bullets that I have here, for example, under cognitive and memory changes, will look familiar to what you see in some of the listings for the general population. But what we're really looking for among people with Down syndrome and people with other intellectual and developmental disabilities is changes against their own baseline. And sometimes those changes are a little subtle and really have to be observed. And it is, people, for example, talk to me about someone not being themselves, so not being as interested in things that they were used to be interested in, needing more. It's not that perhaps they always needed supervision for some things, but now they need more supervision. And perhaps there are things that they did before that they're no longer able to do. And certainly things like changes in hearing and vision. And for people with Down syndrome in particular, one of the things that we're always looking for is late onset seizures, which seems to be higher in this population than we see for others. So if we're measuring people against their own baseline, we need to understand what that baseline is. And so one of the things that we really recommend to people is that we actually get ready for this evaluation, that we have the information gathered beforehand, that sort of to really understand what was happening for this person before and what is now happening so that we can see those changes that may not be as dramatically obvious as they might be for someone else. So, a change questionnaire like the NTG EDSD is really helpful. But it really sort of, if there are records that exist, looking at those records and seeing what the change has been, to realize that people, I think this is true for all of us, that sort of when we go to get an assessment for something, if we're in an unfamiliar place, we don't always um, behave in the same way. Things may not be as obvious. And so to really have good thoughts about how can we accommodate this person, help them to feel comfortable? How do we engage with them? Um, you know, the use of abbreviations and abstract language, be thinking about using nonverbal clues as well as uh, the words, to be thinking about what are the preferred communication devices for this person. But I think most of all is sort of giving the person time, giving the person time to demonstrate who they are, because that's how we're going to see change. If we move too quickly, we may not fully understand what their level of functioning is. And then we don't have the opportunity to observe change. We need to be talking with the family. We need to be talking, or whoever is accompanying the person. We need time, as I've said before. We perhaps need to take more breaks when we're doing this and realize that sort of sometimes just the evaluation process itself doesn't go well. So what are we going to do next? Are we just going to give up, or have we have another plan for how we might move this process forward? So we do know that the assessment instruments that are used for the general population generally are not appropriate. People just don't perform well on those scales. That because largely because of their pre-existing disability. So there's a need to sort of again sort of really make it about change from their personal baseline rather than saying, well, most people can do this and they're not able to do it anymore. Perhaps they were never able to do it. Um, they it's if someone may have always needed help, now needs significantly more. It's not enough that they need help. Perhaps though they were independent in something and now they're starting to struggle. That's a really good marker to be paying attention to. On the other hand, there are changes that are subtle. And often it's family members, longtime caregivers, direct service professionals that who sort of real are direct support professionals who really are the people who are tuned in, who will know that. I've done these assessments for many years. Some people might see me as an expert, but I always say, no, the family members, the staff who are working with this person, they're the real experts. They know who this person is. So if we're going to compare to baselines, it would be really helpful if we were sort of thinking about this and recognizing that we need to be thinking about this earlier, not because we're seeking to say this person, well, they're 45, 50 years old, they must have dementia. No, they may not yet. Um, but if but what we try to do is gather a baseline, usually for people with Down syndrome by about age 35, usually for people with other intellectual or developmental disabilities by about age 50. If we know what their usual functioning is, we're going to be tuned in to look for the changes that are likely to happen. And this is really, it's really important to be gathering this information, but instruments that gather the information are not making the diagnosis. They're helping us to document a person's baseline functioning and how that functioning is changing. There could be other reasons why it's changing. That's, if you like, the next stage. But never see the instrument as saying, okay, therefore, the person has dementia. This is about gathering the information to highlight change. A diagnostic process then starts from baseline assessment. We do a screening because we become concerned. Because we are concerned and that the screening instrument suggests that there are changes, then we do a comprehensive evaluation, and then someone will make a diagnosis. So in the practical strategies for professionals, you'll find a discussion of all four of these steps. You'll also see recommendations for assessment and screening instruments that are specifically designed for people with intellectual and developmental disabilities. There's a really nice table that runs from pages 16 to 18. That should be where you go to sort of really understand what would be appropriate instruments to use. So, but where do you get help? And I think that sort of one of the things that we've seen happening over the last decade is that there is more resources. So we have throughout the country, we have a lot of general population memory clinics. Some of them are open to doing these assessments for people with intellectual and developmental disabilities. They've participated in training. Some of them actually advertise. So check out the memory clinics locally. There are specialized intellectual and developmental disabilities memory clinics. See where the nearest one is. But many clinicians have been receiving training on effective assessment processes. Check in with clinicians about whether or not they've been trained to do this. One of the things most recently that has been happening is that there has been funding for clinical trials around sort of some of the certainly medications, but other approaches to care. Go to the clinicaltrials.gov site and see if there are sites close by you, because again, the part of conducting these trials is there are people there who are trained to do these kinds of assessments, because that's a very critical part of what they're doing. So you'll hear, I always feel like I should never, well, I don't read a newspaper anymore, but going online, sort of I see all of these things that sort of the next big thing in dementia care. And there are big things that are happening. It's not necessarily that we have moved forward, but dramatically. But some of the things that are happening and are starting to be made available for people with intellectual and developmental disabilities are some of these other approaches to assessment. Certainly, there are all kinds of scans that are being tested. I give you the names of some of them. Look them up, think about it as whether, one of the things I'm always concerned about with the scans is whether or not the person can tolerate them. We are talking about much more now about looking at biomarkers, and many of them are blood-based. Many of them are other cerebrospinal fluids. Some of them are retinal. Some are not well developed yet, but a lot of work is happening. And there are sites that are doing some of this work, particularly with people with Down syndrome. A big development in dementia care has been this establishment of mild cognitive impairment, because it's likely then that people are more likely to convert to dementia. We've not done a good job in the past of identifying people in mild cognitive impairment, but I feel as though because of the increases in assessment processes and the determination to establish baselines and measure change, is that we may be identifying dementia earlier. And so the kinds of initiatives around mild cognitive impairment that we're seeing for the general population are starting to happen. And then uh, uh, the use of AI and machine learning algorithms that analyze neuroimaging data is just in the early stages of aiding in diagnosis as well. And I've seen some of the research groups working with people with Down syndrome beginning to look at that as well. So ask those questions, but they're, it's still in the early stages. Amy, I'll hand it over to you.
Thank you, Dr. McCallan. You gave us a really great overview of IDD and dementia, including prevalence, signs and symptoms, and how to assess for possible dementia. So I appreciate that overview. And now we want to jump into how we can move from what IDD and dementia looks like to what we need to be doing differently as we support people. We want to build a bridge from that clinical diagnostic understanding to service design, inclusion, and workforce readiness. So it's important to recognize as aging and disability service professionals, your programs are often the daily life infrastructure for people with IDD. And if you want, you can follow along in the guide. I think it's nearly impossible to fit all of the awesome information that's in the guide into a 1 hour webinar, but we did our best to kind of pull out some of the key topics, and definitely follow along if you'd like, but certainly check it out if you haven't already. Next slide, please. Okay, so why do we need to use a specialized approach? Some people might think, well, if you understand IDD, you understand IDD. If you understand dementia, you understand dementia. But there really is an overlap between the two, and it's important to understand how to use that specialized approach. So there's really 3 big reasons we want to make sure that dementia-capable support depends on baseline knowledge and life course context. So if we treat it like standard dementia care only, we miss the person's disability supports. If we treat it like disability supports only, we miss the dementia capable adaptations. And then services become fragmented and people are eligible for both, but no one really owns the coordination. So I kind of see it as, a ping pong match. A person with IDD is aging, is seeking some additional support or needing additional support on the disability service side. They go over to the aging service side where, a lot of times they're told, well, no, your supports are over here in disability services. So they're not really finding the support they need in either area. And it's that kind of ping ponging back and forth. And then support sits at the intersection of those two systems. Again, there's that overlap. So specialized does not mean separate. It means intentional adaptation. So inclusion is real. We want to build from how the person has always communicated and learned and lived. However, remembering that dementia changes how needs are expressed. So, understanding communication is a really, really big piece of this type of support because behavior supports really need to be adaptive, and remembering that behavior is often a person communicating unmet physical or even emotional needs. And this, I'll try to, if I can remember, I will try to let you know in case you want to look at the recording later, which sections of the guide some of this information is coming from. So for that last slide, it's sections 6 and 13. All right, so what specialized looks like in practice. So we want to make sure that we assume competence and preserve dignity. So making sure the person has as much choice as possible for as long as possible, remembering to use person-centered planning that evolves. So it's really a shift from skill building and kind of, the habilitation to maintaining skills and adapting supports as dementia progresses. Making sure that environments are dementia capable as well as the routines, ensuring things like safety and independence. So queuing, simplification, and having predictable structure and schedules. And then, of course, behavior as communication, responding with curiosity and support, not judgment. So there's a perspective shift for a lot of families and teams here. Again, we've been so accustomed to for across a person's entire lifespan, whether it's within home and community-based waiver programs, and or different types of services and supports, that habilitation was the key, that it was all about progress and a person gaining skill. And so it can be really challenging and frustrating and even scary for families and service teams to start to see some of that regression, or a person struggling with even maintaining some of their skills. So we need to really come into those conversations gently and helping somebody kind of understand that we're going to redefine progress. We are going to really kind of reshape what a meaningful day looks like for a person. And these principles become the criteria you're going to want to use as you're assessing your own organizations and where you're at on that dementia capable pathway. So within the guide, these are in sections 7, 8, and 11. Next slide, please. So this is an example of a common service provider miss and a good, specialized response. So the scenario is a longtime person served in a day program starts refusing activities and becomes distressed when staff try to redirect. So a common miss might be we're treating it as non-compliance or a behavior problem, and then we escalate the consequences for the person. A specialized approach might include using a simple behavior log, so really tracking some of those changes, checking routines and triggers, assessing the person for pain or illness, adapting the activity, and then of course communicating with family and the support team to make sure that everyone is on the same page. So, and this is a point here where we're going to open up the chat. So if you'd like to share some feedback, think about what is your team's current default response when a familiar person stops engaging in the ways they typically have. So what is typically your default response when you see that? If you want to add some ideas into the chat, we'll share those. And so it's really about breaking it down into that, observing, interpreting, adapting, and then coordinating. And there is an example of a behavior log, as well as some other helpful tools in the back of the guide. There's some great appendices there. All right, so we've got some ideas here. So tracking, excellent. Team meetings, good communication. We rely heavily on documentation. Yes. Do another assessment and compare baseline. And going back to the documentation point, even making sure that your team members document what's not working. So a lot of times, teams will feel like I need to document what I was able to do with the person, but also it's important to document what didn't work. What did you attempt to do and the person refused, or it just didn't work out? So really, making sure you're documenting those attempts as well, not just what, worked well, because that kind of gives a full picture for the team to share. So lots of documentation, seeing that team meeting, reassessing. Yes, reassessing is huge. So not just taking that one snapshot, but going back on a regular interval and or as needed, and really reassessing and seeing where you need to maybe pivot or make some changes in your supports and services. Documentation that addresses the conversation had with the person and others. Yes. So that, and a lot of this too helps provide consistency across your service programs, because it might not be as objective as you think. One staff person might think that providing a particular support to somebody looks one way, and then the next staff person is under the impression that they are providing the same support, but it looks very different. So really observing and seeing, if a person is doing better in a certain situation or with a certain staff, checking out like, what is that person doing? Where's some differences between them and that other staff? And it could just be personality or approach or energy, but really kind of investigating that so you can provide some continuity across the person's supports. Yeah, compare with family. Yeah, what's happening at home? Why is it looking different, better or worse than what we're experiencing? Good. Checking medications. Yes. What are all of those, other things that can be happening, physically for a person that might be affecting how they're responding in your program? Definitely. All of those things, all of that, remembering behavior is communication. Are they not feeling well? Do they have a UTI? Are they experiencing some side effects with medications? Very good. Yes. Yeah. Is there a medical issue? Awesome. Right. Everybody's on the right track here. Love that. All right. So let's move to the next slide. Okay. So the guide essentially breaks down what you can do for a quick scan in your organizations within 6 domains. And we have some slides that are going to go into the domains specifically, but just so you know, they're outreach and access, communication accommodations, behavior support approach, meaningful engagement, caregiver partnership and planning, and then of course, coordination and referrals to other support. So this is a gap scan. This is not a full compliance audit. This is really meant for you to go into the different domains and develop goals by identifying maybe 1 or 2 areas that you can improve within those domains. So breaking up the domains, and I even really recommend that you don't place this all on the shoulders of one person on your team, but having different roles and different people who are coming into it with different perspectives. Maybe one person taking a domain and then looking for those 1 or 2 things they can do within that domain. So, whether it's your program managers, your direct support professional leads, nurses, family liaisons, case managers, all of them are going to come into this with a different perspective, and it really helps give you a more robust assessment. So let's see. So their domains are throughout the guide, but they're primarily in sections 5 through 11 and then 13 through 15 if you want to dive into it later on and start some assessing. So next slide, please. We'll look at domains 1 and 2 here. So they include outreach and access. So asking yourself, do we proactively identify people with IDD who are aging and offer information early and before crisis? So this is going to be for a lot of you aging service organizations. Are you, intentionally identifying people with IDD so you can see where you can make some of those specialized responses and changes? Are referral materials accessible using plain language, easy to read formats, and culturally responsive? And then communication accommodations. Do staff use short, concrete language, visual cues, and allow extra time? Do you have a plan for communicating about diagnosis and changes that's guided by the person's preferences whenever possible? And then again, we'll look in the chat here. Let me make sure I scroll to the newest part of the chat. But if you want to answer, where do people with IDD fall out of your dementia pathway? If you want to think about that, is it an intake? Is it assessment, programming, discharge? If you think about it, where do you think there's potentially people with IDD might be falling out of that dementia pathway? And it's important to remember that inclusion starts before crisis. So again, implementing a lot of these strategies and techniques before your organizations and your program are in crisis and really need them. So being really proactive with that. And then you want to build pathways early so families are not scrambling after a diagnosis. And we all know that sometimes those diagnoses can take quite a while for a person to get. And so there's a lot of support and things that need to be put in place way before. Okay, so some of you, let's see where you're seeing that maybe people with IDD are falling out of that dementia pathway during intake, assessment, and appropriate programs. Yeah, it can be really sometimes hard to even get the right assessment. Intake. Yeah, so sometimes right out of the gate. Very good. Returning to house after extended hospital, yes, or skilled nursing stay. So a lot of in those transitions, or when somebody maybe has a shift in their living situation or their level of care, that's when some of that communication might break down. Good. As a guardian, just knowing where to turn for assistance. Yes, just even knowing what resources and supports are out there as a person's needs change. Good. These are all great. And so a lot of this is going to get you thinking about when you start to look at that dementia pathway and where you can start doing a quick scan in your programs. Here's some good starts, right? Here's some good step ones for you. Assumption of already receiving services. Yes, that's a huge one. That's what we were just talking about with the ping pong match, where we kind of just assume that if somebody needs dementia support, they're getting that from aging. If they need disability support, they're getting that from disability services. And so everybody's just kind of thinking that somebody's got it and nobody's got it. So very good. Yes. Okay, so these 2 domains are in section 6 and 15 if you're wanting to note that. So next slide, please. So domains 3 and 4 include behavior supports and engagement and environment. So Do we treat behavior as communication and look for root causes? So pain, discomfort, triggers, unmet needs. Is the person hungry? Are they thirsty? Are they tired? Before labeling it as challenging. Do we use a shared documentation tool so staff responses are consistent? So again, there's that sample behavior support log in the back of the guide if you want to check that out, or if you have any other agreed upon strategies, but as long as it's consistent, so staff are really understanding how to document objective information and how that is communicated across teams and environments. And then meaningful engagement are activities adapted to the person's interests and current abilities with social connection protected. Environment and routines. Do we prioritize safety and independence with predictable routines, cueing, and simple environmental modification? So we want to remember that a structured routine and meaningful engagement can reduce stress and behavioral symptoms. And that's kind of helps us lead into our desired outcomes, which is fewer crises, better quality of life, and less caregiver burnout. And this is in sections 7, 10, 11, and Appendix C in the guide. Slide, please. So domain 5, caregiver partnership and planning. So partner with caregivers as collaborators, right? They're the experts. They have decades, as Phil said, decades of advocacy and system navigation experience, and often know the person best. Support the perspective shift. So again, from that, habilitation building skills to maintaining skills and adapting supports as dementia progresses. And then offer caregiver education that's tailored to IDD and dementia. So this should include communication techniques, behavior symptom management, and understanding disease progression. Build advanced planning into routine practice. So consider future care, decision making, and who needs to be at the table. So define when you'll do those caregiver check-ins. So do you want to do them at intake, after major changes, quarterly? Somebody had commented on a previous slide that you want to do them ongoing. So kind of reassess as you go. So not just at intake, but kind of what are those future points as well, so you can assess for any changes. And then advanced planning conversations really can be difficult for families, recognizing that caregivers of someone with IDD have been their advocate and their primary support for that person's entire life, and now they're really feeling some fear of their own mortality and what that's going to look like for their loved ones. So really understanding that some of those conversations can be difficult for people and hard to initiate, but try to normalize planning before crisis, saying things like, we plan because we care, not because something is wrong today, but just that we care and we want to make sure that we have a good plan going forward. So this information is in sections 8 through 9 and Appendix B in the guide. Okay, domain 6, coordination and referrals. So build a bridge between aging and disability. I think if there was one message that I would really want to highlight across this whole presentation is there's a significant need to build a bridge between aging and disability services. It's quite segregated, and one doesn't necessarily always see how it should link to the other. So, asking yourself, do we have a clear who coordinates what plan across IDD and aging systems that includes case management, medical, program staff, family, doing those warm handoffs. So not just simply giving somebody information about a resource, but do your staff really know how to connect families to dementia specific and aging and disability support? So understanding who's at your AAAs, who do you talk to at the ADRCs, respite programs, adult day, housing, centers for independent living, using a person-centered approach. So do you gather information about a person's life history and their preferences to inform your service plans that includes also the perfect person's strengths, as well as connecting them with needed assessments? And then communication. Do we facilitate care planning with family and friends as needed and support self-advocacy? So within your aging and disability systems, is there a mutual understanding for who does what and where those gaps might be? So where are those kind of opportunities for collaboration? And then within those handoff points, areas where this can often fail. And again, some of you you're kind of ahead of the ball. You mentioned this on some of the previous comments that some of those points where they fail could include diagnosis disclosure, changes in program fit, during eligibility and referrals, and then transitions into another living situation or another level of care. So an example of a concrete action that you can take for this domain would be maybe to create a referral map with specific contact names. So not just agency names, but really like who is the person at those agencies, and re-reviewing these because we know there's turnover and there's changes within agencies. So frequently reviewing who's my contact for that agency, and then helping with that warm handoff. And this information is in sections 13 through 14 of the guide. Okay, so if we look at workforce training, there's not going to be a one size fits all, even within your respective organizations, because you have people in different roles doing different tasks. And so, we broke it down into essentially 3 different tiers. So tier 1 is going to be for all of your staff. Anybody in your organization should understand IDD and dementia basics, communication strategies, and dementia capable approaches. Then you have tier 2, which includes your frontline staff, your direct support professionals. This training should include specific behavior symptom management tools, environmental supports, meaningful activity adaptation, and then of course documentation. And then tier 3, these are your supervisors, your case managers, your service coordinators. These are staff who are going to do a lot of the coaching and kind of like checking in with the rest of your team, coordinating across systems, providing that caregiver support, understanding the referral pathways, and then doing that quality review and oversight. So training alone is not enough. You want to pair training with coaching and simple tools like checklists, a behavior log, activity planning templates. Again, some of this is in the appendices in the guide. And a tip is to use the training checklist. I want to say it's the last appendix in the guide. Use that training checklist as a planning tool, maybe for your next quarter. So kind of review that in the guide and see where you might be able to implement some of those as soon as the next quarter. So that's in section, so we have section 15 is where this domain is, and then appendix E is that training checklist. Okay, so if we had 3 actions to do even within the next 30 days, so if we got really excited about this and not just waiting for a quarter, but even just in the next 30 days, here would be my 3 recommendations. Number 1, run the 6 domain quick scan with your team and pick 2 priority gaps, 1 or 2 per domain. Again, try not to have this fall on one person's shoulders. See if you can divide those domains up across multiple people in different roles. Number 2, adopt one shared tool to improve consistency. So maybe it's the behavior log or something like a routine and triggers template. I definitely don't recommend launching more than one new form at a time. That can sometimes stress out teams. So just kind of picking one tool that you want to implement at a time. And then number 3, launch a 3-month training plan using the sample training checklist. So the who, what, and when, with 1 coaching touch point per month. So really, in closing, we want to remember that people with IDD should not lose access to community and choice as they age. That's really kind of our key message here. And if you want, this is optional, if you want to answer in the chat, finish this sentence, 1 thing I will change in my program is. So kind of based on what you've learned today, have you thought about maybe even just 1 thing that you can change in your program? And this information can be found. There's the appendix C is the behavior log, and then appendix E is where you're going to find that training checklist. So creating a roadmap. Yeah, so that roadmap to referrals is huge, because we know that resources and community services and other things for people change constantly. So really understanding that roadmap and revisiting it. Share the 6 domains with your staff. Yeah, see who might be interested in a particular domain and might feel motivated to tackle that. Training for the hospital staff. Yeah, very good. Confirm pathways between IDD and aging services. Yes, build that bridge. Absolutely. Making community connections to get to know which resources and staff we can work with hand in hand. Perfect. creating question log / community services. Good. Yeah, so even if the one thing that you're going to do right now is just kind of a commitment to learning more. So kind of figuring out, what else you need to be doing. You don't have to know exactly what that is yet. So let's see, move so quickly, it's hard to track. Yes, created the roadmap and then closing gaps in services. Yes. No assumptions and asking more questions of all care staff and family members. Absolutely. Assume that people behavior law with 6 domains regarding we know if we hand the people information on resources to really help lead the person to that resource. Oh, and I'm sorry, my audio. I think I had a little connection issue for a minute. Hopefully it's okay now. Is it better now?
Yes, it just got better when you asked if it was better.
Sorry. Okay. So no, it's not only you, Tara. It was me. Very good. So ask care providers to note changes in behavior and discuss what resources are available. Very good. Yeah, so you're all on a really great track already. Great feedback. I know that we're going to wrap up some slides and then have some Q&A, so I don't want to take up any more time, but I appreciate everybody's participation today. Thank you.
Thank you so much, Amy. Thank you, Dr. McCallion. I do see some questions in the Q&A section of the Zoom platform. Please continue to enter your questions there. You'll see here, this is what you'll see when you link to the guide. Someone had asked if we can send that link out again, so we'll get that pushed out again through the chat. Oh, thank you, Patrick, just did that. And we will move to questions. And Dr. McCallion, we'll start with you. There was a question that came in and was asking if there's a typical length of time between diagnosis and progression to dementia for people living with IDD.
So there's not really a typical time, and part of that is because it really depends on when people are diagnosed. What we do know is that it seems as though the early stages happen more quickly, but some of that may be simply that we didn't catch the earliest phases. But in the sort of moderate to severe stages, that can actually be an extended period because the stages move so quickly or appear to move quickly at the beginning. We might think that the whole thing may be relatively short. I've worked with people where dementia has lasted 20 years, but that's unusual. We tend to think more in the sort of 6 to 8 year range.
Okay, thank you. Amy, anything to add on that based on your experience? Yeah, you'll have to unmute.
Sorry. No, I think Dr. McCallion covered it. Thank you.
Okay, great. So the next question is for you. Could you recommend any trainings? Are there any that you really prefer on person-centered planning for this population, Amy? And then Dr. McCallion, feel free to jump in afterwards.
Sure. I think the Council on Quality and Leadership has a really good person-centered planning curriculum. There are some really great training resources in the guide that include things like person-centered planning. It might not use that title, but it goes over things like understanding the person's essence and their preferences. So it's really kind of woven in across a lot of the training that's already linked in the guide. So check that out. And you're also more than welcome to contact me if you have questions on that. Our organization is actually working on, we already have a menu of IDD and dementia trainings that we provide. to other organizations and as well as inside our organization. But we're going to start to implement more of a positive behavior support approach within those training topics. So if you want to reach out to me, I'm happy to share some resources and information.
Wonderful. Thank you. Anything to add on that, Dr. McCallion?
Just to reinforce, start with what's in the guide. It's a really good point that Amy made, that many of the trainings, person-centered planning underlies it.
Great, thank you. Dr. McCallion, someone was asking if you can talk about any of the baseline assessments that you recommend for people with IDD.
Yeah, so baseline assessments, some of this really depends on how regularly the person has been assessed through their lives as a person with an intellectual or developmental disability. If there are functional scales, if there are behavioral scales that have been used in the past, well then, repeat those scales, because that will help you to see change. If this is someone where that has not occurred, I always feel that the NTG scale is really good at documenting people's behavior at a particular point in time. And again, that's what's going to help you to see change.
Great, thank you. Anything to add, Amy, about that you've seen through practice?
No.
Okay, so the next question, don't mute yourself, Amy, it's for you. Are there any resources that you can speak to off the top of your head for families that you would recommend to people who are caring for those with IDD and dementia? So we've talked about some of the materials for professionals, but what about for family caregivers?
So a lot of the resources that are listed in the guide, while the guide is meant for a professional audience, it absolutely is beneficial for families as well. And and a lot of the training in particular is designed for people who are hands-on caregivers. So they may be paid caregivers, but they could also be unpaid caregivers like family members. So the training materials are really designed in a way where professionals implement them, but the audience who's receiving that information very much can be families and your direct support staff, boots on the ground people.
Great, thank you. I think both of you will want to take a little bit of time to respond to this. So can you talk a little bit about how a professional might go about presenting concerns about someone with IDD who's showing changes that may be related to dementia when the person they're sharing the information with is resistant to hearing that information?
Wow, that's one of the toughest things that we all have to deal with. It is very hard. One of the things that I always encourage people to think about with an individual with intellectual and developmental disabilities and their families is that rightly they're concerned that this is an individual who's always been given labels. And sort of why would we add another label? And I think that that's a legitimate concern. To me, it's only valuable to add another label if we're going to do something, if we're going to find ways to help the individual. And if it means that we are able to then connect people with services. So when I talk with people and they present some resistance, I always talk to them in terms of, okay, I'm not simply trying to give the label, I'm trying to find resources, and here are some of the resources that I think we could make available. But that said, it's personally tough. It's true in the general population too, to deal with the diagnosis. And so we need to be supportive of the individual and what they're feeling.
Great, thank you. Anything you want to add, Amy?
Yeah, I mean, just that I think what I like to start in particular to gain buy-in is really the numbers, the statistics. I think when we start to talk about the prevalence and how our population is aging and how this is becoming such an important thing, whether you're working in aging and disability services, kind of regardless of what industry you're coming from, this is something we need to be paying attention to. And so I think if you just, I don't know, maybe I'm just a numbers person and that's the most convincing way for me. But if you start with those statistics and the data, you really can't argue the importance of it and why people should be motivated to learn and to kind of make some changes.
So I know we talked a little bit about the National Task Group EDSD tool. Can you talk a little bit about how it can be used not only by professionals, but how it can be understood and possibly reviewed by a caregiver so they understand, how maybe they can see like, oh, there's a change from point A to point B.
Yeah. So, it again, this is not a diagnostic instrument, and it's also an instrument that it is better that someone who is providing direct care to the person, whether they're a staff or a family, that they have the best information to provide. What I find is that two things happen. That first time that people do it, they've sort of realized that, okay, I'm saying that the person can't do something now, but I know that they did it in the past. And that's an indicator of change. When you repeat it, you're going to see more clearly that there are things that you recorded before. This is a time for honesty in filling it out. Wanting to give people the benefit of the doubt perhaps will mean that we won't catch change as quickly, but we're not looking to have people declared to have dementia unnecessarily. So I think that sort of the way in which the questions are phrased and scored, you'll see the change. So it is something that anyone should be able to use.
Great, thank you.
Yeah, I mean, just to add to that, the EDSD is really designed for anybody to be able to use it. And as Phil said, it really should be completed by someone who knows the person best. And I can't stress enough doing it early on. So not really necessarily waiting until you're already seeing some concerns, but it's recommended that for somebody with IDD that you start at 40 years and then doing it every year thereafter. So if it's somebody coming into your program, maybe implementing it and kind of infusing it into your intake process and then having a plan for, during every annual meeting or review of their services, you're doing the EDSD again. And that's how you're going to really start to kind of look at it and trend it from previous screeners, because just doing it once isn't necessarily going to tell you a whole lot. You're going to need to do it multiple times.
Great, thank you. Someone's asking about, in implementing any of the, you kind of answered this with the EDST that it can be used by anyone who knows the person well. But in any of the other assessments or forms that you recommend, is there special training that you recommend, or are there special trainings that you can recommend for people who are kind of just starting off in this field of working with people with IDD and dementia? And I know there's some in the guide, but are there any special ones that you really feel strongly about?
Well, I do feel strongly about the ones that are in the guide because I think they're the best established of the scales that are out there. So many of those scales do have manuals and training that's available. There are groups that do training. The NTG, for example, does training on assessment, but there are other groups as well. I think too that there are echo trainings that are available. I'm reluctant to say specifically because some of those trainings go up and down in terms of their availability, but sort of to look to those resources and to look to some of the advocacy organizations. But I think the starting point really is from what's in the guide.
Great, thank you. Anything to add,
Yes, and I
Amy?
was just going to add, aside from, gosh, I just love Phil's Irish accent. I can't get enough of that. But so the University of Wisconsin has really great resources, and it's specific to training people on how to use the EDSD. So they have some great PowerPoint slides. They have some pre-post tests. You know, the EDSD comes in a bazillion different languages. So I know that they used to just have it posted on their website, but now I think all you have to do is send an email or fill out an online form. And they are usually happy to share their materials that they created. So that's a really great resource if you're looking for specific training to use the EDSD.
Great, thanks so much. Well, we have to close here. We're going to go to our last slide. I just want to thank everyone for joining us today for this National Alzheimer's and Dementia Resource Center webinar. And I want to thank Dr. McCallion and Amy DeWitt-Smith for their excellent presentations and interaction during this question and answer period. We hope you all join us again on March 17th at 2 p.m. Eastern for our next webinar addressing food insecurity for people living alone with dementia. We'll send out information to register for that webinar shortly. And please contact NADRC-webinars at rti.org if you have any questions. And that's it for today. So thank you, everyone, and have a wonderful rest of your day. Take care.